So we talk about sports injury prevention. I like to remind folks that you really can't prove that you actually prevented something from happening that didn't happen. And injury prevention programs, as we've talked about, are really just risk reduction programs where we try to decrease somebody's risk of injury by addressing certain risk factors that we know might predict injury. So those may be things like a decrease in flexibility or a poor strength or something like that that's associated with more injuries. So it leads to my question, can we really predict injuries? Well, obviously we can't be sure of the future, but when we look at patterns of injury rates and the associated factors, we can statistically look for those increased risks of getting hurt if someone has these particular risk factors. Or on the other hand, maybe they're at less risk of an injury if they don't have those risk factors. And we can generally look at these risk factors through screenings. So a screening is simply a test or a collection of tests that look at specific factors that are associated with that increased risk of an injury or disease. And we have healthcare screenings like for cancer, for heart disease. And when we see these positive screens, that basically tells that individual they need to have further testing to actually diagnose the problem. And that's where I need to point out something. A screening in itself is not diagnostic. A screen looks for signs and symptoms that can be associated with the disease or injury, but a screening alone is not definitive for a diagnosis. So be very careful and understand that there are more specific and sensitive tests that we need to use in order to come up with the accurate diagnosis. Now, these movement screens have become popular in athletics recently, and what they're doing is looking at these deficits in specific areas of movement that are thought to be related to performance or injury. Some of these examples may be something like the functional movement screen or Fusionetics. These are a couple of the common systems that we see in use in evaluating athletes. Now, these screens are made to be very easy to implement across a variety of settings, populations, and in theory, it's a great idea to be able to identify these factors that may be able to identify performance or risk factors for injury. But the question is, are they really specific and sensitive to be definitive? That's the question. There are a lot of studies, there's a lot of data out there on movement screens in a variety of sports and even used in occupations like for the firemen or the military. But what do they really tell us about athletic performance and injury prevention? And where do these movement screens really fit in the overall performance health picture? So that's why I reached out to my great friend who literally invented some of these athletic screenings, Dr. Mike Voight, to help us answer some of those questions. Dr. Voight is a physical therapist and certified athletic trainer. He's a professor at Belmont University, Physical Therapy School in Nashville, Tennessee. He's worked with countless numbers of athletes from high school to professional and many sports, as well as a few country singer superstars. He's an expert on movement screens and even developed the Selective Functional Movement Assessment Tool, or we call it the SFMA, which he teaches regularly. And he's also the executive editor-in-chief of the International Journal of Sports Physical Therapy, publishing countless articles on sports PT and movement analysis. So thanks for taking the time today, Dr. Voight, to talk to us about movement screens.
Well, Phil, I don't know what we're going to talk about. That was a great introduction about movement screens and screening in general, because you kind of really took the air out of the sails a little bit with that, but you hit the nail right on the head with that. So it'll be an interesting discussion. I couldn't think of anything better to do than spend a morning talking with my good buddy, Dr. Page here. And you and I are just having a little chat today, but what the viewers don't realize, we talk all the time and share ideas and brainstorm and contribute and challenge each other to get better on this. So this is just another discussion like we normally have on a weekly basis. So it's a pleasure to be with you this morning.
Exactly right. Thanks, Dr. Voight. Listen, before we get really started, tell our students a little bit about kind of your background, how you got to be where you are now.
Yeah, I think in sports, it just sort of followed a typical pattern, much like you, Phil. What we did is that I have a dual background. I started off as an athletic trainer, got certified, did my master's degree in athletic training at University of Virginia. And I kind of realized I want to be more in a clinical sense, at least I thought at that time. So after I graduated with my master's degree in athletic training, I went to physical therapy school. And a lot of times in sports, as everybody will realize, and students over time get it, it's a lot of being in the right place at the right time, and opportunities, if you just look, will open up when you least expect it. And so I was hired right out of physical therapy school to work with the Philadelphia Eagles as a physical therapist or third assistant. They didn't have all these assistants back then, as you and I both know. Everybody did everything kind of. And then from that, I always tell people the story. That's back when we didn't have indoor bubbles or stuff like that. They didn't make enough clothes to stay warm in Philadelphia and when we were playing. And one thing led to another. And within about a couple of years, I was in Miami, Florida, and I was working out of a clinic, but worked with the Miami Dolphins as the physical therapist for the team. And then again, a lot of things we do in sports medicine is about relationships. It's our friends and the relationships, the people we meet, and helping people along the way. And when I grew up in the Pacific Northwest and Portland, Oregon. And when I was doing my, in University of Oregon in Eugene, but when I was doing my undergraduate work in athletic training, part of my work was with the Portland Trailblazers, and the medical staff, the head trainer and the general manager, they were hired by the Miami Heat and on an expansion team. And they was that 3,500 miles away and all this, but they knew I was in Miami. So I got a phone call, said, we need help setting up a medical team and doing this to the Heat. So I sort of migrated from the Dolphins into the NBA and spent several years working in the NBA as a physical therapist. And we certainly know others that have followed in the footsteps. And then I went into private practice, still had that part of private practice because I like working with people across the lifespan. It's fun, but when you're in the NFL, NBA, you have a specific cohort of individuals, and I'd like to do more with it. So I went into private practice. And then along the way, the next big step was I actually believe when you learn something and you get good at it, at least maybe in a very narrow scope for me, you should try to give back. And an opportunity, just like you are, came up to go into academia in Nashville, where I am right now, talking to you. And I became a professor at Belmont University, and I teach the orthopedic track and sports physical therapy. And I love working with passing all the knowledge on and learning from the students. We learn from them as well. The challenge of that, I still keep my hands in the field, working with various teams and athletes. So I work out of a sports medicine clinic that largely specializes in hips. So we see lots and lots and lots of athletes that come in from around the world. And then the other extension, I suppose, with sport is, and I'm sure it'll come up in discussion today, is I work real close with the PGA Tour. So I have tour professionals that I work with that are out there at various places around the country or sometimes the world, if we're talking British Open. So that's kind of a quick nutshell of things I do. It's they always say, I would say the same thing to you, because people look and say, Phil, how do you do this? You do it. And it's the old adage, if you want to get something done, ask a busy person, because they'll figure out a way to do it. And that's you and I are that way. I know we're busy all day with stuff, but it just seems natural. And I think I know you well enough to say this to our audience. And the thing is, if you're doing what you love, it's not really a job. That's right. And so, yeah, we do lots of things, but if it ever got old or there's something I know you and I have talked, we'd go to another career, do something else. So it's all fun.
All fun. And this is part of the fun, is being able to have a chat like this and give back, like you said. So real happy to do that. So moving back to that great introduction, I could see all the parallels and why you and I get along so well. It's kind of like we kind of seen the same things, and I feel exactly the way you do. So bring us back to where I really wanted to talk to you was about these movement screens. And, we talked a little bit about how there's a lot of these, the way that people are trying to get at that edge. And these movement screens have come about as saying, well, that kind of makes sense. If I can look at how someone moves, can I make them a better athlete, or look for the deficiencies to get to that next edge? So before we get started in that, tell us about what are movement screens really in your definition? What do they tell us? Why do we use these things?
Well, and that's a $1 million question. I'm going to go down two roads with this. From what your introduction said, I just want to reiterate what your thought process is on that to the audience. And number one, I guess by definition to me, a screen is nothing more than some sort of a test or a cluster of tests that can give us some baseline information about a movement or a topic or something like that. They are not diagnostic. assessments maybe going down the road can be diagnostic. These are not diagnostic. This just provides us information. The example I might use, you said it, I'll just build off it. You actually gave 2 or 3 great examples. You go to your family practice for your physical, and they take blood pressure and heart rate. Mm-hmm. And they don't look at that and say, oh, well, you have heart disease, or you're going to have a heart attack, or you're going to do this. No, if something's off on that, they do additional tests. When we go look at any of those type of medicines of that, we go to it, and they're going to come back and say a blood work. Well, there's an abnormal thing in your blood work. What do? We order more definitive tests to come up with a diagnosis. So it's just to give some in my mind, some baseline information. What's happened through the years, and I've been involved with this, and I know we're going to discuss it, is that, and I don't know where it happened, it's just sort of happened, or an evolution with this, is a lot of these screens have become more definitive. And what I mean by definitive is that we'll talk about FMS or others, but if you, they've been bastardized to a point that if you get this score, you're going to get injured. Yeah. People say, oh, yeah, you're going to get injured. Or you look at it, or you're not going to be good at this performance. No, it's just a baseline number of movement. It doesn't mean you're going to get there. To my knowledge, and I know you and I both read this literature, I don't believe there's a single test out there today. And I think you qualified it really nice in the introduction. Maybe someday we'll see something. But today, I can't think of one test that is definitive that would say, if you fail this, you will be injured 100%. No, we can say you have an increased risk of injury, a 2-time risk, a 3-time risk, a 5-time risk. It can be whatever, but it doesn't mean you're going to be injured. And likewise, if you pass the screen, it doesn't mean you're not going to get injured. Right. And we know that from sports, things happen. Yep. But we're trying to identify people at risk with that. I do think there are certain things, we'll get into it, that you could look at a screen that potentially would cue you into performance, that you might perform better, but it would put you perhaps into the category that you have the tools to perform, or maybe it would drive you to some training that would allow you to perform even better with that. So it's a cluster, in my mind, it's a cluster of tests that just provide us some baseline information. Hopefully, and we'll get into this, but hopefully it would give me some comparison data to a similar cohort of individuals. And it's not all the individuals. So if I'm working with an NFL team, I don't need 60 numbers of everybody. What I'd really want to do is cluster my things around a wide receiver, a lineman. Quarterbacks are separate in and of themselves. So it is somewhat even position specific. My golfers all kind of do the same thing. So that is one similar cohort, but I think it's even position specific when we look at it. So I think it gives us this information where we can start to create a picture of what normal is, but it doesn't necessarily, I really firmly believe it doesn't necessarily mean somebody's going to get injured. We can't say that. And I don't know that it 100% can tell me who's going to be a great athlete. It just tells me if somebody has the tools to be a great athlete.
Right. One of the components of.
One of the components. Yeah.
And so you touched on this a little bit. Did the movement screens, so as a whole, so movement screens have different components. And let's take, like FMS, I think they have 7 movements, if that's true, that's correct. And then do all of those fit every sport? Or like you were saying, do we take some and apply parts of it, or maybe even different screenings? Are all these screenings the same for every sport, or how are they used related to the sport?
Yeah, that's a great question. And I think that oftentimes, at least with the FMS, gets into it a little bit what people think. And just to give people some background on this, I didn't develop the FMS, the functional movement screen. That's something that was a byproduct of Gray Cook. Gray Cook was a student of mine when I taught at University of Miami, and he worked in the clinic with me in Miami. And I watched him develop this, and he was actually trying to bring neurological PT into performance and manual therapy. But in the development of this, here's the guy that developed it. He never, ever said, this is an injury prediction test. He never said, I can pick out injury. What he did was, he said, this is a baseline screen of movement, of just looking to see how somebody moves. And what his point is, now to get to your question, is with the FMS, and we could debate of the 7 tests. We could debate which are good, but he has an overhead deep squat. Okay, you might call it overhead deep squat. I might call it a squat. A geriatric therapist or somebody working with a senior population might call it a sit to stand activity. It's all the same thing. It's just it's how we name it, what we do. But the idea was that if your foundation of movement is not good, or there's some variations in that, and again, if it's not perfect, then we can obviously fix it and maybe try to improve the efficiency of how somebody moves. That's all it's looking at is baseline. But you have to have that before we get into sports specific. So the FMS was never designed to be an NFL screen, a Division I football screen. It was a baseline movement screen that from cradle to grave, not actually cradle to grave, but probably as soon as we go upright, so age 3 or 4 to the end of looking at movement. Once you're good at that, you earn the right to go into sports specific. Give you an example, golf. As the background here with Titleist, I work a lot with Titleist Performance Institute. We have a separate screen for golfers that look specifically at the attributes that we think are important to a golfer. There may be some overlap, but it's more specific. The FMS doesn't tell me things about how good you're going to be or things about potential in golf. It just tells me how you move. So we move. So to get to your question, I think there's multiple screens out there. And/or we use our own common sense and come up with some screens. Mm-hmm. But once in theory, I clear my FMS, I'll wear that hat, but I have basic movement competency, a good word with that, or efficiency. Now you can move into sports specific or movement specific drills. Football has it. I just talked about golf, baseball, throwing programs. Mm-hmm. Those type of things all can come in. So I think you could find tennis. Tennis has different things that are important again, it's a rotational sport, but it's different than golf. So there's different screens at that point in time that would be movement or sports specific that you would move into. And all you're doing is you're starting on a funnel, a basic foundational movement, and we're working down the funnel to the neck. So our screens start to get a little bit more specific to the task we're asking these people to do. But I don't believe, again, I think there's some basic individual tests that might be potentially universal across multiple sports. I don't think there's one screen or the ones that are commercially kind of people use that can be everything to everybody. You have to start tailoring it to the individual and to the activity that individual is doing.
So I like the funnel analogy is really good. And I think it came back to movement is movement. And we talk about to our students, it's a developmental progression. Everyone is born and learns to move a certain way. We're programmed to be like that. And then as we get more specific into the sport that we're working on, there are these little details, like you mentioned, tennis, golf, baseball. Right. So these screens are really that top level. I think that's an important point, is that these top screens are really that opening of the funnel that catch a bunch of flies, if you will.
Yeah.
And then what we do is we're able to look and see, are those flies really a problem? Do they actually get through the funnel to affect our performance? And that's where we have these next level.
Right.
All right. So if we take those, and then we're talking about a couple of things. We talked about, can we predict risk factors, or can we find risk factors for injury? Can we look at anything that might help with performance? But what came to mind also was return to sport.
Right.
And so that's kind of a third area that we can use. I believe didn't you have a book that you had worked on with these tests for return to sport, functional return?
We did one, a while back. It's been a while, so it's probably, some tests are universal, but functional progressions, return to sport, I did with Steve Tippett.
Right.
So we just looked at what we had at the time.
Yeah.
And I think, in our lifetime with you and I know we're doing research together with this, but I think in our lifetime, we're going to see things get better, because if you think about that, and not to get off topic with the screens, but on the return to play or our functional tests or screening tests, let me bring it back to that. Largely in previous years or past, I suppose with this, it's really judged by two things, how we look at this. Well, actually 3 things you can put in there. It's going to be what our eyes tell us. Mm-hmm. We just look at it and say, this doesn't look right. And I call it the 3 C's. when we look at that carriage, control, and confidence. Can they stop and start without undue stress, with this? Does they look kind of symmetrical in how they move? And then you look at their eyes. Are they kind of confident in their movement or looking at? But all of those are relatively subjective by what I think and maybe using my experience. And then the other two things you and I have used through our careers, two very simple tools, a stopwatch and a tape measure. And those give us some objective numbers, but it doesn't tell us really a whole lot about anything. If I'm running a T-test, I'm having you go run different directions. I just know how fast you did the whole task. I didn't break it down any component. I think what we're going to see with computers, high-speed film, and it's not just much the tools, it's the interpretation of the data from the tools. Right. That's the key for us. I think we're going to get it broken down. We're making leap years in it right now. And I know you and I have been discussing this in the past, and we might even get into today, some of the things that are critical, I think, in the movements that we look at. We're getting better. But yeah, I definitely think it's all of this comes into the big picture of I love the performance side of things. Performance / then injury prevention or return from injury. And I think those go hand in hand because, and I'll just throw a little wild card to us, but let's just take ACL tears. We'll just take our athletes that have ACL tears. It fascinates me that here we are, in this decade and it depends on who you read the literature, but you're probably more versed in exactly what it is now, but I've heard that the re-tear the different articles, and they're good articles, but the re-tear rates of either the same side ACL repair or the contralateral side can be on the low end 15 to 20%. And I've read a couple papers as high as 40% in the next 1 to 2 years.
Yeah.
Okay, think about this for a minute. Let's go to the extreme. If it's 40%, something fundamentally changed in that process, or we didn't rehabilitate these people correctly. Right. We weren't using the right metrics, or maybe they weren't sensitive enough to pick up that there really was something still going on. That shouldn't happen. Right. But in this day and age, it does. So maybe we don't have the right tools or aren't using them correctly. So I do think a return to play comes in as well.
Yeah, and you touched on, I'm glad you brought us into technology, which is kind of behind this evolution of movement screens. So when we were doing movement screens 10, 20 years ago, when these first started, like you said, all you have your eyes, sometimes your ears, and a couple of other things, but that brought quite a bit of subjectivity to it. Right. And so that leads you to the question of, validity, reliability, and of course, having the more objective measures gives us better opportunities for validity and reliability. Right. Because as we know with technology, we were talking the other day about frame rates, going from what you say 15 to 90 or whatever it is like leap years ahead. And this technology will continue to evolve, and I think that movement screens are really, as we've talked about, in the infancy, and we're really held down by technology. So all that being said, I also, in these discussions, I like to talk about statistics because it's
I knew that was coming. You're my statistics guy.
Such a nerdy thing.
I know it's coming.
That I wanted to touch base real quick with you. Tell me about your thoughts on the validity, reliability of these types of measures. How do we look for those types of things?
And you can correct me because you are the statistical expert on this. But let me just tell you how I view these things in a simple lay term for people looking at it. Because I think people interchange those a lot, reliability and validity. Reliability is like my reproducibility. So if I give you the test today, if I gave it to you 5 times today, do I get the same results every time? And that's important in a tool or whatever test we're doing, because if there's so much variability and from test 1 to test 2, I don't know if it was just random chance alone that there was change. So do I get consistent readings when I'm doing my reliability on a test? I will just tell you, that's the easy one, because I do think a lot of these tools that we're using today, if applied appropriately, a lot of them are fairly reliable. Mm-hmm. You'll get the same results with it. Now, you also need to look, and I'll just say something on this one, I guess my mind was wandering a little bit, but like Kinects, Microsoft Kinects, gaming type things. we can look at those, and they do give reliable, fairly reliable information. But understand that around each measure that comes in, there's some variability of that measure. So in other words, if I raise my arm overhead, then I raise it up to 180 degrees, does it come out 180 degrees every time that I do it? Well, I can tell you in some of these tools, it might be 175 one time, 180 one time. There's a lot of error measure on that number. And you need to know that when we're using these tools. The big one is validity. Are we measuring what we say we're measuring?
That's right.
And I think that is Pandora's box. And I love your opinion on this too, but that's Pandora's box on all these screens and tests. The technology we're talking about is because, for example, we ran a T-test and we used our stopwatch and we got a time. I can look at the time, but, I'm 20, that would be a lot, but I'm 10 seconds below the average times. So what? What's the problem? Who knows what the problem is? I don't know what all I can say is, yeah, it's measuring from A to B to C, but I don't know why. I have no idea. So if somebody says, yeah, well, you've got a right ankle problem. No, you can't say that. That's not, we don't know what it is. So are we measuring what we purported or trying to do or measure? And that's a big one. That goes back to your lab. That's working with you guys with what you're doing. I know, Phil, is trying to answer that question. Certainly there are things that are both reliable and valid, but I find a lot of the tools we use today are kind of cool, fun things to do. They're reliable, but they're not really valid.
Yeah, and exactly. And validity and reliability are, as you said, sometimes interchanged because the definitions aren't necessarily clear, but they're very related. It's kind of like they kind of go hand in hand, right? Yeah. So the first question is a chicken or egg sometimes. Right. Should I be valid first? I think you need to be valid first. You should be measuring what you say you're measuring. And then, of course, being able to do it over and over again and get the same result, which is the reliability. People may say, well, you got to have the reliable measure first. I'd say, well, it doesn't really matter if it's not measuring what you say it's going to measure.
Correct.
And today, so we know there's lots of different types of validity, right? And a lot of what we apply actually, though, is face validity. Right. Does it make sense based on what we see in front of us?
Right.
Does that overhead squat really translate to the lineman being able to get down into a 3-point stance?
Right.
Makes sense to me. But does it really predict something? And that's, again, where the statistics have to come in. Otherwise, when you see these types of movements, all we're going off of is this type of face validity that it makes sense, or maybe this biologic plausibility, that type of stuff. And I think
I'll give you an example, Phil. Let me just throw in one that's great in my world of golf. And it's one that Titleist says quite a bit. But I'll just show you how things could also get twisted a little bit with what you're saying. And you mentioned that overhead deep squat. I can tell you that in a golfer, that if they fail that overhead deep squat, there's a swing fault. It's called early extension. Doesn't really matter, but it in essence, what it means is as you're doing your downswing to hit the golf ball, your whole body mass will move forward. Your pelvis and everything moves forward. Golfers will tell you in their world language, it feels like I'm getting trapped on my downswing. I have no room for my arms. But they're moving forward and some of these people will move forward 3 and 4 inches off of their center of mass forward. And we find that definitely correlates. Okay. I can tell you with 100%, they will early extend. Okay. But here's the thing. It doesn't mean their performance, it goes back to what you see with your eyes. It doesn't mean their performance is bad. Maybe it's somewhere, and this is sort of tying a little bit together, but maybe somewhere along the lines, they've learned to compensate really good with their hands or something else, and they can make up for that deficit. So what I see with my eyes, hey, that ball's going straight down the fairway. They're looking great. You're right. It didn't mean that other stuff didn't happen, but it didn't mean it was a detriment to what they're performing. Mm-hmm. So you have to be very careful what you define that validity is, what we're looking at. And then you can't take, and this happens all the time, as you know, with sports. You can't take that and then say, well, and because you're going to early extend, your performance is going to be decremented. Now, I know guys that can early extend and won a major. So you can tie it all different ways, but I like what you're saying with that, with our face validity. And I 100% agree with you. I think what you said, I'll recant it. I think validity is the most important thing. Are we measuring what we say we're measuring? Figure that out first, and then we'll see if the tool is reliable or fix reliability somehow. Your chicken and egg. I would venture to guess a lot of the tools that are out there that are coming into play in the last 5 years and going forward, I would venture to guess it's the other way around, that the companies that develop these or people that developed them, they're reliable first, and they're making huge assumptions, or they're leading us to believe, very clever in their advertising, that it's a valid tool. I don't want to pick on any companies, but I've seen companies out there that make some claims about stuff, and there's no way they can make the claim. It might be a reliable tool, but I don't think it's valid.
That we talked a little bit earlier about the black box.
Yeah.
And they'll say, well, we can get this number reliably, but where did you get that number from? And it's kind of my question is, so what? As you said earlier, and when you're saying it, I have all this data, but so what? What does that mean?
I'm going to say this to your group, to the students and everybody listening today. And this is how the hair goes up on the back of my neck a little bit, this factor. Here's how they get around it with coaches. Is we're talking about something now that is with testing, screening, looking at things for performance or injury prevention. We're talking about something that's extremely, extremely important. So I don't want to discount what we're talking about, because I do think there's things we can use with this. But what happens, I think, is most people, as you just said, and again, we're not statistical nerds doing this, but reliability, validity, and all the different forms of validity, we don't understand it. And here's what gets the hair kind of up my neck. Some of these companies that make, I wouldn't say they're less than reputable, but here's how they're going to sell you on information. I don't know if you can see everything. I'm going to get a piece of paper. Here's your email to me. I'm going to get a piece of paper, and it's going to have some beautiful charts, very easy to read charts, either a radar graph or a bar graphs. And let's just do injury prevention. And it's going to be our performance. And they're going to be, because we all think of traffic lights, red, yellow, green. Green, you're good. Red, you got a problem. And I can look at this and go, good night, I got 5 things that are red, and I've got to do this. Coaches love that. They look at it, but it doesn't mean anything. FMS, the thing on that is, I can't tell you, whoever started this bastardizing, there was a paper. I was actually in on one of the early ones. Just real brief, you were correct, 7 tests. If you're perfect on every test, you get a 3.
Right.
If you're, well, I'm going to tell you some numbers. I do this for everybody here because some people are familiar. That's one of the more common ones. 7 tests, perfect, you get a 3. Understand, this is one of the problems with the FMS. If pain, and we can talk about this next, but if pain is present, you get a 0 and the whole thing's over.
Right.
So if on any of those 7 maneuvers, somebody hurts or it reproduces some pain, you're done. You have a 0 for everything. You can't say, oh, test number 5 was a 0. No, the whole thing's a 0. So the reality of it is, if you're not hurting, okay, the range on 7 tests is each one 1 to 3. So you're either going to get a 7 or a 21. If you're just breathing, you got a 7 with that 21. And so we did a study, and I can come back and get some other numbers. This fits into something you asked me. We did a study one time with a very select cohort of NFL players, and we followed them for a season. And we found in this very select group that if they scored under 14, these people under 14, they were potentially at risk for injury. In other words, we retrospectively looked, and more of the injured people scored under 14, and there's always aberrant injuries that can occur. So the number got thrown around. 14 is an injury factor. And then that got spread around. And so now you've got coaches, it's in pro teams and Division I teams. When I go in to talk to people, they'll say, what's the FMS score? What's their score? What's their score? And first of all, it's sports specific. I'm going to give you a number. Cleveland Cavaliers. So in football, we established 14, right? Cleveland Cavaliers as a team scores as a team at one season, a little over 12. I can tell you, I work with military quite a bit. An operational SEAL team right before deployment, 12.8. Player of the year in the NBA multiple times. We won't go into a name. Player of the year. On any given day, get this, on any given day scores between 9 and 10. Realize again, if you're just breathing, you're going to get a 7.
Yeah.
So the numbers don't matter to the validity on some of this. You can't apply it to some of these things. It's very, very specific. And quite honestly, I would rather if somebody scored all 2s and had a 14, and somebody scored 3 on 5 of them and had 1 on 2 of them, that they would be at a 19. I'd say the guy with 19 is a little more problem than the guy that was at the 14 one, because there's obviously some asymmetries there that I want to check into. So it's all relative to what you're looking at. You have to use your head on these things. Mm-hmm. But the problem you get back to on these stats, and we were talking about and bringing it back around to these validity and things, you're going to have to apply common sense to these. It's not a one size fits all. Right. You can't just say, oh yeah, 21's perfect. No, 21's not perfect. I remember going to a track and field meeting. I was sitting in and I was so impressed. The track coaches were sitting there. They're field coaches. They weren't sprinter guys. They were field coaches. And these field coaches were sitting there saying, yeah, we use the FMS all the time for injury, or for performance. And I'm like, oh, that's interesting. These guys know about it. And I started hearing more, and the guy says, yep, we use, and I actually don't remember the number, but I'm going to use 14 again as a number. I actually think it was 12. It was like 12. But the guy said, yeah, anything above 12, they're not going to make the Olympic team. And I'm like, what? And the guy says, no, they're not a discus thrower, not going to make the Olympic team.
Above 12?
If they were above 12. And basically what they were saying was, if they are in those higher numbers and they're symmetrical, they're not going to perform better. He said, they might not get injured.
Yep.
The guy said, you might be telling me they're not at risk for injury, but I'm going to tell you they're not going to be on a medal stand.
Wow. Great.
Because you need that asymmetry in their rotation, what they do with discus or like a pitcher would have. We know sometimes those are good. Well, that's not built. The FMS doesn't say, oh, well, if it's a baseball player, use this set of numbers or use this. So it gets back to what you said earlier. It's not a one size fits all with this. And I was shocked by it. And I went and started looking at some of their numbers. And sure enough, the people that were performing better in that specific task, the hammer toss, shot put, and discus, they were asymmetrical. Mm-hmm. But it probably is why they were good at what they do. Common to everybody that were listening. Baseball players, with their shoulders. Yeah, there's asymmetry right and left on certain things. Probably what. And I know one of our good friends, Mike Reinhold, he told me one time, he goes, if I get a physical therapist or a trainer comes to me and said, hey, I've done a good job. He goes, and here's my baseball pitcher and they're symmetrical right and left. He goes, one, I'd never hire him. I'd fire him. I'm sure not going to draft that player if they're symmetrical. So again, it got sort of rambling on that one, but it's not a one size fits all. But I go back to the stats on this. Are you measuring what you say you're measuring?
Right. And measurement is really the key here. And I think it led to the, as you appropriately say, bastardization of this. Yeah. And I think if you took the numbers out of it, and you really started thinking about it, it makes a lot more practical sense in usability. But when you take the numbers away, as you said, people go, oh, wait, hold on. Now I don't understand what I have to do. It's not easy enough for me. And that's where then this computer technology side comes in and just spits it out and goes, oh, well, that's really easy. Now I don't have to do anything. I don't even have to give you a grade. The computer is going to tell me the grade. And that's where I think we're getting away from the original way that these were developed, which was understanding movement first and the predication of how this was built to evaluate movement, and then using our own brains within the context of the situation, which is what I tell students now. Is it's kind of like it's my new way of thinking about evidence-based practice, which is the three-legged stool: best evidence, the patient, and then the therapist. But it's really about what is the best information that we know with this particular set of tool or whatever we're using in the context of the patient and what they're going through, the type of patient, and then also how do you as the therapist or healthcare provider then link all that together. That's kind of my way of thinking about what evidence-based practice 2.0 may look like.
Right.
Instead of being dummied down by having the computer spit it out, or having, as we used to, look at the MRI and read the diagnosis. And there's your diagnosis. we know that that's not true anymore. That
Sure.
those low backs, for example, discs and things like that aren't the cause. They're radiographically a problem, and they're spitting it out from a static
Well,
image.
they look at the hips, Bill. I mean,
Hip,
with us,
same
with
thing.
FAI, you know, in the NFL combine, was almost 84% have radiographic evidence of a problem, and they're asymptomatic.
Yeah. And that goes back to what you were saying earlier, too, is if you're doing these tests in season, are there any athletes that don't have pain?
Correct.
No. I mean, you're always in pain, and you're going to have pain with these. And the other thing is, and they won't, and you know that they don't want to say they have pain.
Right.
And then also, as you've said, they've developed these great compensations.
Well, that's in an athlete. I mean, one thing I've seen in my career, and I know you've seen the same, we've talked in the past with some of the great athletes you've worked with as well, is that the difference, and I tell students this, the difference between myself and the athletes, and I'm not an athlete, but if I have an injury or have pain, whatever, all of us probably have a default compensatory pattern we'll go to. We're going to move unless you have ankylosing spondylitis, you're just every joint's fused. You're going to find a way to move. It's just going to be pretty. The thing I've noticed in athletes, which kind of fascinates me, it's another whole topic, but fascinates me, is the great athletes have multiple compensatory patterns. So I had a lower quarter injury, and I have one compensation I go to. Michael Jordan might have had 15 compensations he can default to. He's got all these patterns, and which one's right? I mean, I think that's what that's a whole nother topic, but which makes an athlete great is they have these multiple patterns of compensation. But I will say, pain, as you said, and I'll apply it back to my golfers, pain will change the way you move. Right. We know that happens because nobody wants to move in pain. Now, what I think happens with those athletes, I can't prove this, but I think what happens is if they were honest with you, our soldiers, our special forces guys, same things. If they're honest with you, they probably have pain. But I actually think, and this is a whole nother wild concept, but I actually think there's a tolerance level of pain that once they don't start compensating until they hit a tolerance level of, on a 10-point scale, everything's a 1, 2, or 3, and they can live with that. That doesn't even bother them. They've learned to move with 3. But you take it to a 4 or 5, they start to compensate. Whereas to me, I might compensate at a 1. But I see that in the athletes with this. But we know that they start to change. And what happens is, in some of the skilled athletes, a skilled event, golf is an example. I've had guys come in and we've looked at them, and I start to see changes in their movement patterns with the computers, not my eyes. Although they'll tell you something. The athletes are pretty smart. Your patients are smart. I mean, this particular athlete I'm thinking of came in and said, hey, I'm losing distance, professional golfer. I'm losing distance off the tee. I'm losing 20 or 30 yards off the tee. It looked good to me, the swing, but he knows he's not hitting it the way he did. I checked through our computer systems and looked at it, and all of a sudden his left hip isn't moving exactly like it was before. I won't go to details what we looked at, but we knew that there was something he wasn't decelerating on his left side. I said, well, what's going on with your left hip? And he's like, oh yeah, well, let me tell you about my left hip. He goes, I went to the doctor a few weeks ago. I've got DJD in there. They want me to do a total hip, and I'm going to probably do it in November of this year so I can have some time off and recover in sort of off season. And our answer to the guy right now was, no, you're not going to have it done. This was August. You're not going to have it done in November. You're going to have it done next week. And he's like, no, I'm not. I'll give you 15 million reasons why I'm not going to do it. Finances. And what we actually told him is, look, if you don't fix this now, you're already starting to develop compensatory motor patterns to work around that pain or that thing you have. If those become fully ingrained, you may never get your swing back. Yep. And he thought about it, and it was actually 2 days later he had surgery. Wow. But I've had other guys that didn't do it, and they developed some abnormal patterns, and sometimes you can't break them with that. So the point is, the screen picked us up, or some of these tools, that was more of an assessment, but can pick those things up. So you're right. I'm not sure in season what some of these screens tell us if pain's present. It'll knock it out. And that kind of gets to one of the things you brought up earlier. The FMS, like I said, if pain is present, you're done. That number, that is not a valid, it's not a reliable number, number one. And you're not measuring what you say you're measuring because they're moving different. That's what started this whole SFMA, right? Selective functional movement assessment. And what the selective functional movement assessment did was brought in pain to the equation. So remember I said, your screens and your training and your sports specific deals, pain's not present. You're just looking at how well the tolerance is to their movement, the movements that are specific to their activity. With the SFMA, pain comes into the equation, and we actually we put that into the algorithm to figure out where it is. And so there's things we can do there, but understand if pain's present, they're not going back to full activities. We're going to figure out what the problem is, identify impairments, fix impairments, and then test them back out, working up that pyramid we talked about before of here's a baseline movement screen, and then here's sport-specific movement screens.
Yeah, you've had perfect segue. I was going to ask you is the SFMA. It's not as popular, I would say, as the FMS is, but it's also designed to be different. It's similar, but I wanted you to take us through kind of how SFMA developed, how it's different when you would use it, because it's not necessarily something that a coach or an athlete may use for themselves like an FMS. What is it? How do we use it? Tell us a little bit about it.
Yeah, I'll make it real quick on that. The SFMA, and I'll do the party line. So we said before that whatever screen you like to use, there's a baseline screen we're using. I'll stick with the functional movement screen, but it could be any of our basic screens we're using, or even sports specific as we moved up that pyramid. The pain changes the way you move. We said that. So all of those screens that we use for golf, tennis, baseball, just basic movement FMS, if you have pain, you're not getting reliable. You're not measuring what you think you're measuring there. They're going to move a little differently. So, and pain's not normal with the movement. So the selective functional movement assessment brought pain into it. So we look at some of the same movement patterns. We're going to look at cervical, we look at shoulder, we look at trunk, flexion, extension, some rotation and balance. The squat is consistent with that. But here's the difference. When we look at movements, we rate the movements, very simplistic. You rate movements, it's not a 1 to 3 like these other tests are. It's very much looking at, can they do it? Yes or no. So are they functional or dysfunctional? Functional means they do it with all the parameters we're looking at. And then the second big one is pain present, yes or no. So does this movement cause or reproduce pain? Yes or no. So the reality is, you think about it, here's the deal. I run a simple screen of baseline assessment or baseline test, and I can score you of one of 4 ways. Functional, non-painful. You can do it, it doesn't hurt. Move on. I can move up the scale now. You're good to go. It could be functional. You can do it, but it hurts. That's something I got to take into account because it hurts. It could be dysfunctional and you can't do it and it hurts. And so that's a problem. Or it could be dysfunctional, non-painful. Just give you a real quick example for the viewers today. Because I see this all the time and I could retire on this one with this screening. Low back pain in golfers. 40% of golfers across the lifespan suffer low back pain at some point playing golf, and or it stops them from golfing. I can't tell you how many times I will do an assessment, run through my SFMA, trying to look at it, looking at the total body. And what I'll find is in many, many, many cases, the hips are dysfunctional. They don't have range of motion in their hips, and they don't hurt. They're non-painful. And the back might be functional, painful, or back might be functional, non-painful, but usually it hurts there because that's what they're treating. And people make the assumption that where it hurts is where my problem is with the SFMA. Well, in general, the SFMA says that's not necessarily the case. Right. So take this golfer as an example. Low back hurts. I've got people being treated for years to come in. They have minimal range of motion at their hips. And you start looking at their hips, they're going to tell you, Doc, my hips don't hurt. And I'll just sort of look at them. Well, of course they don't hurt. They're not even moving. They're not even working. So if you think about it, I told you earlier, the body's always going to find a way to move. You're going to compensate. Yep. So if the hips aren't moving, guess where that movement's going to get taken up? The low back and potentially down at the knee. Sometimes they'll have some knee pain with it, but largely low back. Yep. All you got to do is identify. That's what the SMA kind of does. It puts you, it doesn't, again, it's not a diagnostic tool. Okay. So it's I think one step beyond maybe a screen or a step in the right direction towards diagnostics. It's like this.
Yeah.
The tool was designed to a roadmap of where you should look. As an example, there's a sporting event going on today in the world. What that SMA will do, it would lead you to the city. It would lead you to the stadium where the event's being played in Baton Rouge, leads you to your stadium. It'll probably even get me into the section where my seat is, that big stadium there. And it'll probably quite possibly get me to the row where my diagnosis lives. That's it. It's going to be up to you to use your diagnostic test to find that seat. But trust me, if you can find the row where that diagnosis lives, you're way on the way to helping this person and getting them going. You're in the game now. It's not going to tell me, oh, you've got a ligament problem or you've got a facet joint restriction, you got whatever. No, but it's going to tell me I've got a stability problem somewhere about my knee, a stability problem somewhere, a mobility problem at my hip. You figure it out from there with your diagnostic tools, kind of like these screens do. So the difference being the SMA takes into account pain, where these other screens don't. So once you clear, so let's talk about, I did my SMA, I found out you had hip mobility problems in our golfer. We fixed those hip mobility problems. We rescreen it. Everything's good. You're functional, non-painful down the line. Well, guess where I go? I go now back to my performance screens. Go back to those performance screens, run them, and see where we are now to identify maybe issues that could have been contributory to the problem in the first place, or which would have maybe led to injury, or might help you with performance down the road. So it's all on a spectrum of where we are. One going to more involved, one going to more injury, I guess, the other end going to performance.
Right. So the SFMA, again, great plug for the physical therapists, athletic trainers who are really looking for more, and it's, as we said, it's not diagnostic, but it leads you closer to that diagnosis than it would from a general screen, which is that funnel, right? So we're talking about, well, this is where it'll bring us to.
And I'll tell you what it is. To me, Phil, it's that funnel, but I'll add to your funnel story. It's an hourglass. And what I mean by hourglass is, we've been talking about the funnel, the net. We work into this. When pain's present, it's an upside down funnel. It's the hourglass. On that bottom part is where I start to figure out where all these impairments are and work my way back up to get out of it. So I liken it somewhat to an hourglass or a double funnel is kind of how I look at it. I realize the neck is narrow, but that's where our baseline is. Then we screen up to go upwards for performance or down with impairments.
Very good analogy for sure, because you definitely can do all those points. And I tell the students, one of the things that you always teach in SFMA is look for the elephants, not for the mice.
Correct.
And so making sure that you're not seeing things that you think that you want to see or not there. It's really, and that's that subjective, objective part.
Yeah. And along those lines, Phil, you're exactly right. I would also say this, that it fits right with what you just said, is we're looking for the elephants, not the mice. You know, they're looking for that 800-pound gorilla in the room. But people will say, but I'm dealing with elite athletes. I've got athletes here at the university, and they don't have elephants with dysfunctions of that. No, but if you're picky, and discerning with your eye, those little things that people have, the mice that we might call with other people, they become the elephants. They stand out like a sore thumb.
Yeah, and it's another thing I tell the students. It was there. You just didn't know where to look or how to look at it. It was there the whole time, but now your eyes are going to be open to it so that you can be picky. Well, let's wrap up. This has been fantastic, and we could just talk forever. Every time
we need to do it again. That's fun.
Usually 60 minutes every time you and I talk. The last part of what I wanted to do is, as we bring this back, for the students that are looking for performance health enhancement, and kind of what are some of the things you want to look for in a screening tool that would be helpful, and maybe give us the best of both worlds of injury prevention / performance enhancement.
Yeah, that's a tough one, but I would just say that and I'm not trying to plug any one person or doing it. I would say, depending on what the individuals wanted, what we're looking at, I do think there's some baseline things you can look at and sort of modify your own with and just, you can look up on, and even in our journal, International Journal of Sports Physical Therapy, we have lots of articles on screens, things that people submit annually with that. I would think where you go with that is, depending on the activities that you're participating in, maybe kind of look at screens in that area. I'll plug one because it's in my background. But if I'm in golf or looking at golf performance, I think the Titleist Performance Institute, it's just mytpi.com. They probably have the best golf screen, bar none, for performance. Maybe it would help with risk. I'm not 100% sure, but it definitely is with performance. And again, just to reiterate at your beginning, just because you score well on one of these performance screens doesn't mean you're good. It just means you have the ability to be good. So when I look at it and say, I look at your score and I say, Phil, you tell me you're a 0 handicapper, and I look at your screen and it's awful. Then I'm going to sit there and say, look, I don't know what you're doing, but I bet you putt incredibly well. And I bet you can get up and down around the green incredibly well with this, because driving the ball off a tee is not very good with what I'm seeing here. So skill always comes into play with our coaches. Or a person could tell me, it could be just the opposite. And they have all the attributes to be good, but their handicap's low. So there's a lot of improvement there that we can figure that out. So I would look at that. On base U, they have baseball, hitting, and pitching, and softball. They're out there, figure skating, hockey. They all have different, there are specific batteries of tests, screens, we've been calling, that would work for that sport. You just have to look at them, and then maybe it's kind of develop the coaches that might be listening, or people going into it, look for some of their own. But there are standardized tests that are out there. I think you just need to, part of it is use some common sense. And I'm not giving a great answer, but if I knew what the skill set was for your sport, it takes lower body power. I just pulled something out of the screening battery is going to be lower body power tests. It might be vertical jump testing. It might be horizontal long jump testing. So I think you got to know what your activities, what you're going back to. So it gets back to me where I said, I don't think there's one size fits all for everybody. I think there's a one size fits all for baseline movement.
Right.
But that doesn't take us into performance. That's where you got to know your activity and be able to break it down and figure out, watch a lot of film, watch a lot of activity, what makes a good athlete, and now start putting those tests together. But skill's still going to override that. Coaching and skill is still going to, you can have all, in other words, I can have all, you're a good chef. Let's put it this way. For people that are watching, don't know this, but Phil is a great chef. And I can tell you right now, Phil could send me one of his recipes. I do see him. Yeah, I see his pictures, all this. And I've eaten with him. But you can send me the recipe, but guess what? If I cooked the same thing you're cooking at my house and you're cooking it, there's no way mine's going to taste like yours, because you have that skill set as that chef that knows that little ins and outs of seasonings and the little things to make it taste the way it's supposed to taste, where I can follow a recipe. And anybody can follow a recipe. That's follow a screen. A great chef knows how to look at that recipe and then tweak it with seasonings and whatever to make it perfect. That's kind of what I'm saying with these screens. We can go through some basic things and use it, but a good coach, a good therapist, a good trainer, administrators, they're going to know how to take that information and tweak it to what they need, what they're looking for. And trust me, maybe a place to leave it, Bill. Every professional team, and probably a lot of SEC schools or big schools, they're all trying to do that right now. They're figuring out, how do we take this information that's available to us today, or some of the new technology, and tweak it so that we have an advantage.
Yeah, I'm glad you brought up the recipe analogy. I use it all the time with gumbo, because I can tell you how to make a gumbo, we could have the same thing, but you'll have a totally different taste.
That's what I was actually thinking about, was your gumbo. I can't ever make it like yours.
And so that's a great point, that there's going to be these little variations. But I guess to wrap up, what one of the things that I like to wrap up actually a lot of these with is getting back to the research. When we talk about what to look for, you want to find that tool, as we've talked about, that has the validity and reliability. And it may not be published as such, because we may have to take pieces and parts, like you said, to look more at the the validity behind it. But you have to be skeptical and don't bite on the marketing, right?
100%.
And that's the things that I want to make sure that the audience knows is be skeptical, ask questions. Just because Mike or I say this is a great tool, you still have to go out and look for the answers yourself, because again, it's the context. This is great, but in your context, in your professional experience, we may have the best evidence that we have a lot of validity and reliability, but does it fit in your context with your sport, your athlete, and then what you're able to do?
Correct. 100% right.
Well, thanks a lot, Dr. Voight. This was always fun to talk to you about movement screenings and how it fits into injury prevention and performance. And I appreciate you spending the time with us today.
I enjoyed it, Phil. Thanks for having me today.
All right. Thanks so much. And we'll talk to you soon.
You got it, buddy.